Happy Friday, everyone. Welcome to the first grand rounds of October. Today we have a wonderful double header, and I'm going to turn it over to Dr. Horn here in just a second to introduce our speakers. If I could just ask everyone to please direct your questions to the chat. They'll be sent to the panelists here, and we're going to go through both of our speakers first, and then we'll take questions for each of them together at the end. And with that, I'll ask Dr. Horn to please introduce our speakers today.
Thank you, David. So I'm really pleased to introduce our two speakers today. So just briefly, to promote the career development of trainees, the Department of Medicine created the Diversity Academic Development Scholarship Awards, or DADSA, in 2020. These were recently renamed the Equity Academic Scholar Awards. So if you're looking for it or more information on how to apply, you can type in EASA, EASA, and UW, Department of Medicine. These awards provide partial or full salary support for 1 to 2 years at $50,000 per year. And they're primarily aimed at people who are either in the later stages of fellowship or in the earliest stages of a faculty position. While this award is open to all applicants to promote a more diverse faculty, we particularly encourage applicants from groups who are historically marginalized and minoritized communities with disabilities and/or with added family responsibilities. And examples could include people from disadvantaged backgrounds, as I said, applicants with disabilities, people who identify as underrepresented in medicine group, or applicants who identify as part of the LGBTQ+ community. As well, we also encourage people who are primarily engaged in health disparities research to consider applying. So I don't want to take up too much time. This year, we have 2 recipients and presenters, and I'm really looking forward to the talks. First up will be Yogeswaran, who's an acting instructor in the Division of Cardiology. Second will be Limonte, who's an assistant professor in the Division of Nephrology. And I will refrain from giving you more information on their background since I think they'll be doing it themselves. So I will stop sharing and turn it over to Vid.
So thank you everyone for being here and for the Department of Medicine for having me and for helping support my early career as a researcher. So today I'm going to be talking about atrial cardiomyopathy, an emerging risk factor for cardiovascular disease. And I have no relevant disclosures today. So to start with some background on myself, I grew up in London and Brooklyn, and my parents moved to the Pennsylvania suburbs about a year before I started college. So I went to Case Western Reserve University in Cleveland, Ohio for my undergrad, and then moved to Minnesota to go to the Mayo Clinic for medical school. And it was at Mayo that I realized I wanted to be both a cardiologist and a clinician scientist. I had several mentors who showed me that I could do both and could really have an impact by combining both parts of that into my career. I then moved to California for my internal medicine residency at UCSF, where I realized I just really loved clinical medicine, and then was lucky to match here to Seattle for my cardiology fellowship at the University of Washington. And during my second and third year of cardiology fellowship, I realized I still wanted to combine both research and clinical medicine, and during my third year, decided to formally commit to a physician scientist pathway. So this year and last year, I've been a postdoctoral fellow with Dr. Floyd at the Cardiovascular Health Research Unit. I'm also a master's student in epidemiology, and I'm getting additional training in advanced echocardiography at the UW Echo Lab. So I'm excited to start my early career as a physician scientist here. Dr. James Floyd is my primary mentor at the Cardiovascular Health Research Unit in the Division of Medicine or Department of Medicine, but I have several secondary mentors: Dr. Kirkpatrick in cardiovascular imaging, Dr. Nazim Akoum, Dr. McClellan, Dr. Otto, Dr. Freeman, and really so many people in the Division of Cardiology and Medicine have mentored me and continue to mentor me as I navigate my next steps. Clinically, I love advanced echocardiography. I also really enjoy being a general cardiologist and being in the CCU. And research-wise, Broadly speaking, I'm interested in novel ECG and imaging risk measures that can be used to detect early onset cardiovascular disease in diverse patient populations. And my current focus is on the screening and prevention of atrial fibrillation. So, why atrial fibrillation? Many of you are aware that atrial fibrillation is the most common sustained cardiac rhythm disorder. And over the last few decades, there's been an increase in both the incidence and prevalence of atrial fibrillation. The reasons behind this are complicated, but they're thought to be related to our aging population, as well as a rise in chronic medical conditions. If we look at some statistics from the Global Burden of Disease study, in 1990, there was an estimated 30 million individuals living with atrial fibrillation. And in 2019, those numbers had doubled to 60 million individuals. Even then, those numbers are a significant underestimation because so many cases of atrial fibrillation go undiagnosed every single day. This is important because if we treat atrial fibrillation, we can decrease the risk of strokes by about 60%. In this figure on the right that shows pooled studies from the 1990s comparing warfarin to placebo for patients with non-valvular atrial fibrillation, there was a pooled risk reduction of 64% for reducing stroke. Across population-based studies and clinical cohorts, we have learned that if we treat atrial fibrillation early, we can decrease the risk of cognitive decline, dementia, heart failure, and overall mortality. Therefore, it is essential that we develop ways to identify those who are at risk for atrial fibrillation and its associated complications. So, how is atrial fibrillation related to this topic of atrial cardiomyopathy? New research over the last few years suggests that adverse atrial changes, or atrial cardiomyopathy, are actually independently associated with so much of the morbidity and mortality previously attributed to atrial fibrillation. And the European Heart Rhythm Association Expert Consensus Guidelines identifies and defines atrial cardiomyopathy as any complex or structural, architectural, contractile, or electrophysiologic change that can affect the cardiac atria with the potential to produce clinically relevant manifestations. This talk and most of the research to date has been focused on left atrial cardiomyopathy. So the pathophysiology behind atrial cardiomyopathy is somewhat complex, but hypertension, coronary artery disease, obesity, and other underlying mechanisms can lead to oxidative stress, which can activate pro-inflammatory cellular pathways. These underlying pathways can promote cellular changes and microscopically and subclinically can lead to endocardial dysfunction, fibrotic changes, changes in electrical substrate, and direct changes to the left atrial size, volume, and filling. Endocardial dysfunction of the left atria can promote stasis. This can lead to a procoagulant state and the release of von Willebrand factor, which can independently contribute to stroke. Fibrotic changes and changes to the electrical properties of the cardiac atria can independently promote ectopy and atrial fibrillation. And if you change the left atrial size, volume, and the way it fills, it can impair filling, cause annular dilation, and independently lead to heart failure and valvular dysfunction. As many of you know, these pathways are interrelated. Atrial fibrillation can lead to heart failure and stroke. So we can see that atrial cardiomyopathy can lead to these things, but what diagnostic tools can we actually use to measure and study this new entity? Atrial cardiomyopathy can actually be detected from any routine 12-lead ECG using P-wave indices. The P-wave represents the site of atrial electrical activation. And several large studies have shown us that increases in P-wave indices, abnormal values, are associated with incident atrial fibrillation and ischemic stroke over several large cohorts. However, one of the main limitations of this prior work is that most of it is focused on predominantly European cohorts, and less is known about the relationship in other racial and ethnic groups. This has limited our ability to understand P-wave indices as a generalizable risk measure. So one of the questions I studied this year wanted to explore that association further with the following aims. So what is the association between these ECG measures of atrial cardiomyopathy, aka P-wave indices, and atrial fibrillation in Black adults? And for AIM-2, our secondary outcome wanted to study that association with ischemic stroke. In order to evaluate this question, we looked at data from the Jackson Heart study. So the Jackson Heart study is a large prospective cohort study of cardiovascular disease in African Americans aged 21 to 84 years old. Recruitment started in 1999, and we have more than 13 years of longitudinal follow-up data. It is a large NHLBI cohort, similar to MESA and ARIC, and it is the largest investigation of heart disease in African American adults. There are more than 5,000 study participants who have high-quality ECG and outcomes data. For this study, our exposure of interest were these P-wave indices derived from 12-lead ECG. Our outcomes, primarily atrial fibrillation, secondary outcome of ischemic stroke. AFib was identified from ECGs, and both AFib and ischemic stroke were identified from discharge codes and Medicare claims data. And for our methods, we use multivariable Cox regression with adjustment for established clinical risk factors. For our main exposure, we evaluated the following P-wave indices that have been heavily studied in the literature. P-wave duration is suggestive of conduction delay between the right and left atria. PR interval looks at the delay between atrial and ventricular depolarization. P-wave terminal force in V1 is considered the most potent P-wave indice, and it looks at the duration of terminal force in V1 times the amplitude, and values greater than 4,000 suggest abnormal left atrial structure. In fact, it's considered more than 90% specific for increases in left atrial filling pressure and increases in size. P-wave index is arguably the most accessible. It's reported in essentially any 12-lead ECG, and it looks at the net direction of atrial depolarization. Here are primary covariates. The first column showing the covariates for atrial fibrillation and the second for ischemic stroke. These are derived based on prior epidemiological cohort studies. So for our results, after we excluded participants with prevalent disease, we had 4,900 participants in the study. The mean age was 55 years old. Approximately 1/3 of participants were male. And this was a relatively healthy cohort. Only 3% had self-reported heart failure. We had a median follow-up time of almost 14 years, during which 9% went on to develop atrial fibrillation and 4% went on to develop ischemic stroke. And for our primary results, this table shows the magnitude of association for each continuous P-wave parameter. In that top model, I show the P-wave parameters individually, and in the bottom model, we adjust for all three together. So starting with the top for our primary model, when looked at individually, PR interval per standard deviation increase in unit has a hazard ratio of 1.11, so an 11% increased risk of atrial fibrillation per unit increase in PR interval during our study period, and a p-value that is statistically significant at 0.02. For our next indice, we look at P-wave duration. So per standard deviation, the hazard ratio is 1.14. So 14% increased risk of atrial fibrillation per unit increase, and a p-value that is significant at 0.01. And then for P-wave terminal force in V1, per standard deviation increase, there's a hazard ratio of 1.26, so a 26% increased risk of atrial fibrillation during the study period, and a p-value that is strongly significant at less than 0.01. In the second model, when we looked at the parameters together, we observed that P-wave terminal forces are the most potent. So again, the hazard ratio there is 1.24. So a 24% increased risk during the study period after adjustment for the other indices, and a p-value of less than 0.01. PR interval and P-wave duration no longer have any statistical significance in this model. In this next set of results, I show the addition of our secondary covariates. So in that top model, it's our primary model that we just showed, but with including a complete case analysis that includes the secondary covariates. And in the second model, I show the results with the addition of additional ECG, laboratory, and echocardiographic parameters. So again, PR interval, P-wave duration, and P-wave terminal force in V1 per standard deviation increase are still associated with an increased risk of atrial fibrillation in Black adults after adjustment for additional covariates. And that strongest association is seen in P-wave terminal force in V1, which had a hazard ratio of 1.21, so a 21% increased risk over the study period. For a secondary outcome, I show the results for ischemic stroke. So in that top model, I show our primary covariates, and the second model, I add for history of CABG, CRP, BNP, and echocardiographic parameters. Starting at the top, so for ischemic stroke, there was no significant association between PR interval, P-wave duration, and ischemic stroke during the study follow-up period. However, P-wave terminal force in V1 per standard deviation unit increase had a hazard ratio of 1.22, so a 22% increased risk of developing ischemic stroke during the follow-up period, and a p-value that was significant at 0.01. With the addition of our secondary covariates in that second model, we see similar results. Again, P-wave terminal force was associated with an increased risk of ischemic stroke in Black adults. Additionally, we adjusted for that primary model covariates plus time-varying atrial fibrillation. So that's development of atrial fibrillation during the study follow-up period, which showed similar results to our primary analysis. P-wave terminal force in V1 had a statistically significant increased risk of developing ischemic stroke independent of the risk of developing atrial fibrillation during the study follow-up period, and had a p-value that was statistically significant at 0.01. So we also tested for effect modification across our results. The only positive interaction was between P-wave terminal force in V1 by age group. So in individuals less than age 60, so our younger cohort, individuals who we know very little about both atrial fibrillation and ischemic stroke risk factors, an increased P-wave terminal force in V1 per standard deviation unit was associated with a higher hazard ratio for both outcomes in younger adults, as you can see by the star, compared to in older adults. So those were our continuous results. Next, we looked at P-wave indices by what might be more interesting to this audience as categorical values based on their clinically acceptable thresholds. Here are the prevalence estimates. So short PR interval was the least common in our cohort. It was only seen in 62 individuals, so 1.5%. Abnormal P-wave duration was the most common, seen in 46% of individuals. And the next most common was that abnormal P-wave terminal force in V1. Again, the most potent P-wave parameter, seen in 10% of our cohort. For atrial fibrillation, when we evaluated our results by clinically acceptable thresholds, starting at the top, we can see that the strongest association appeared to be seen in short PR interval, which had a hazard ratio of 2.67 during the study follow-up period. So almost a threefold increased risk of developing atrial fibrillation compared to those with a normal PR interval. However, because only 1.5% of our cohort had a short PR intervals, we have very wide confidence intervals. Then if you go towards the bottom and look at the second strongest association, it's an abnormal P-wave terminal force in V1, again, seen in 10% of our cohort, which had a hazard ratio of 1.74. So at 74% increased risk if you had an abnormal P-wave terminal force in V1 compared to those who had a normal value. However, when we evaluated the abnormal clinically acceptable thresholds for ischemic stroke, we did not observe any statistically significant associations. You could argue that most of the P-wave indices capture right atrial function, which is less important in stroke. Additionally, only 4% of our cohort developed ischemic stroke over the follow-up period. So these wide confidence intervals may have missed some associations, including a possible association in P-wave terminal force in V1. So taken together, what does all of this mean? So in our study, we found that P-wave indices, so electrocardiographic measures of atrial cardiomyopathy, are associated with an increased risk of atrial fibrillation in Black adults. This is similar to findings in European cohorts, which supports that P-wave indices are a generalizable risk measure for atrial fibrillation. We also observed that P-wave terminal force in V1 was associated with an increased risk of ischemic stroke independent of that risk of developing atrial fibrillation. This supports that P-wave terminal force in V1 could be an underlying marker of atrial cardiomyopathy across all adults and could be a potential screening target across future population-based studies. So our study has several strengths. It's high-quality data from a prospective cohort study, and it is the largest study of P-wave indices in African American adults. However, like many studies, there are some limitations. There is a limitation to a clinical AFib diagnosis in African American adults who arguably have a higher prevalence of subclinical atrial fibrillation. Additionally, this is an observational cohort study, so we cannot account for residual confounding. So for future directions, actually working on several analyses, looking at imaging measures of atrial cardiomyopathy, which are arguably more specific than ECG measures. Currently, I'm working on evaluating left and right atrial function in cardiac MRIs using the UK Biobank cohort, which shows promising preliminary results. Eventually, the goal is to expand this work and study these associations in other population-based cohorts with available imaging data, such as cohorts that have echocardiography, and the new Asian American, Native Hawaiian, and Pacific Islander cohort mosaic, which is starting its enrollment this fall. Additionally, I hope to evaluate the association between atrial cardiomyopathy and other associated outcomes. There's actually very little that's being done to look at valvular heart disease, and it could be argued that right atrial function and left atrial function could predict mitral regurgitation and tricuspid regurgitation. So, in conclusion, I think the future of atrial cardiomyopathy is very bright. Atrial cardiomyopathy appears to be a generalizable risk factor for AFib-associated outcomes, and it could be a potential screening target to identify high-risk patient populations. But we need more research to explore these associations further, and I'm excited to start my career as a physician scientist in this emerging space. And that is all I have.
Hi, everyone. Are you able to see my slides okay?
Those look great.
Great. All right, I'll get started. So hi, everyone. My name is Christine Limonte. I'm a nephrologist and clinical researcher, and today I will be talking about autophagy in diabetic kidney disease. I have nothing to disclose. I'll start off with sharing a little bit about me and my research goals. Then I'll provide some background on autophagy and diabetic kidney disease before sharing my preliminary research data on molecular autophagy subtypes in diabetic kidney disease. So little about me. My parents are Cuban immigrants, ultimately settled in Miami, Florida, which is where I was born and raised. And then I went to college at Brown University in Providence, Rhode Island, medical school at University of Pennsylvania in Philly, and then did internal medicine residency at Northwestern in Chicago before settling finally here in Seattle at the University of Washington, where I completed my clinical fellowship in 2020, stayed on for a research fellowship, and am now an assistant professor in the physician scientist track. Broadly, my research interest is in deciphering mechanisms underlying diabetic kidney disease using biomarker and translational bioinformatics approaches. My career goal is really to serve as a bridge between these approaches, clinical and bioinformatics strategies. And specifically, I hope to develop sufficient knowledge and skills in both clinical research and bioinformatics strategies to devise clinically relevant research questions that can be answered using these multi-omic data sources and bioinformatics techniques. And my hope is that in continuing to center clinical research approaches, I'll be able to keep my research as mechanistic and translational as it may be, patient-centered, and that it'll really pave the way for individualized care. Additionally, this combined skill set is essential to clinical implementation of bioinformatics-derived findings that I'm interested in pursuing as a long-term goal. Last year, I was fortunate to be awarded a K23 Career Development Award by the NIDDK to pursue a research project investigating autophagy and diabetic kidney disease. And this opportunity is really what's acting as the foundation for the building of this bridge. So I developed an interest in diabetic kidney disease as a clinically and pathologically heterogeneous process. Diabetic kidney disease is one of the leading causes of kidney failure in the United States. And we treat it, with a one-size-fits-all approach, but the patient population really presents in quite different ways. A rate of kidney function decline varies among individuals, and diabetic kidney disease manifests with a broad range of kidney histopathological abnormalities. So the question becomes, how do we parse out this heterogeneity to identify people with diabetes and chronic kidney disease that are at highest risk of progressing to kidney failure? Could identifying molecular disease subtypes allow for earlier diagnosis, enhanced prognostication, and targeted therapies? And this is really where tissue becomes the issue. We can use kidney tissue in diabetes to better understand the mechanisms underlying the disease at the molecular level. And then ideally, we can identify markers in the blood and urine that reflect those molecular processes in the kidney. This is actually one of the goals of the Kidney Precision Medicine Project. The Kidney Precision Medicine Project, or KPMP for short, is a national research consortium that's obtaining kidney biopsies in people with common causes of chronic kidney disease, diabetes, and hypertension, with the goals of furthering our understanding of disease mechanisms and identifying novel mechanism-based disease subtypes. This is a population that does not typically get biopsied in clinical settings because biopsy is not really expected to affect diagnosis or management of either diabetic or hypertensive kidney disease. And in the KPMP, kidney biopsy samples undergo comprehensive molecular phenotyping with transcriptomic, proteomic, and metabolomic analyses, generating a wealth of data that can be used to understand the molecular mechanisms underlying chronic kidney disease. And now I'm going to go on to share some of my preliminary data from my own research examining a molecular process, autophagy, in human diabetic kidney disease. And this work uses tissue single-cell RNA sequencing transcriptomic data from the Kidney Precision Medicine Project. First, some background on autophagy. So the purpose of autophagy is to degrade cellular materials, such as damaged mitochondria and other organelles, protein aggregates, lipids, etc. And then these degraded products can be recycled and reused by cells or eliminated completely. Autophagy is triggered by cellular stress, namely starvation, reactive oxygen species, inflammation, and overall promotes cellular survival. Damaged mitochondria or protein aggregates sitting inside cells can cause oxidative stress and cellular dysfunction. Autophagy gets rid of these toxic products before they can injure cells further. And autophagy is really a dynamic process that begins with formation of a membrane called the phagophore, which then encircles cytoplasmic cargo, forming an autophagosome, which then fuses with a lysosome, which contains degradative enzymes, forming an autolysosome. And it is within the autolysosome that degradation occurs. We know that autophagy is impaired in diabetic kidney disease. I mentioned autophagy is triggered by starvation. Diabetes is essentially the opposite of this. It's a state of hyperglycemia and nutrient excess. In the short term, cellular stress from hyperglycemia may actually activate autophagy, but in the long term, hyperglycemia ultimately diminishes and impairs autophagy. And this has been demonstrated in numerous laboratory models, but research in humans has been limited, namely because autophagy is such a dynamic process that's hard to study in static tissue. My goal as part of my K23 is to define clinical, molecular, and histopathological patterns of autophagy in diabetic kidney disease. This is the first aim of my grant. So to do this, I've taken 32 adults with chronic kidney disease, CKD, and diabetes, and 25 controls without chronic kidney disease or diabetes from the Kidney Precision Medicine Project for whom single-cell RNA sequencing data is available. I compared expression of autophagy-related genes in proximal tubular cells between people with and without diabetic kidney disease, and then clustered participants with diabetic kidney disease by their patterns of autophagy-related gene expression. And I'm mostly going to focus here on the results of the clustering analyses. And the reason I'm focusing on proximal tubular cells is because these are some of the most energetically active cells in the kidney. And we had some preliminary data pointing to abnormalities in autophagy in this specific cell type. And my goal here is really to see if we could parse out this big bucket of people with diabetes and chronic kidney disease into clinically meaningful molecular subgroups based on molecular data, here, autophagy gene transcription patterns. These are the baseline characteristics of my diabetic kidney disease and reference KPMP participants with available single-cell RNA sequencing data. I want to acknowledge that while the sample size may seem small, this is actually pretty substantial for single-cell RNA sequencing. Focusing on the diabetic kidney disease group, about half of the participants are male. Most are over 50 years old. There's a range of diabetes durations. 97% have hypertension, 78% are on RAS blockade. And there's a distribution of hemoglobin A1Cs with about 1/3 having a hemoglobin A1C less than 6.5%, 1/3 with an A1C between 6.5 and 7.5%, and the last third having an A1C greater than 8.5%, or sorry, greater than 7.5%. And the mean GFR in our population was 48 milliliters per minute. And the median urine albumin creatinine ratio was 500 milligrams per gram, so macroalbuminuria. Biopsies were adjudicated by a team of nephrologists and kidney pathologists who established a primary clinico-histopathologic diagnosis. The big surprising lesson here was that not everyone with diabetes and CKD actually has diabetic kidney disease. Notably, only 34% of people with diabetes and chronic kidney disease had evidence of diabetic kidney disease on biopsy, which I'm calling diabetic nephropathy, pathology-based diabetic nephropathy. 22% had a primary biopsy diagnosis of hypertensive nephrosclerosis, so hypertensive kidney disease. 22% had non-specific or mixed findings, precluding a clear diagnosis. These are labeled cannot be determined. And 13% had other findings, IgA nephropathy, fibrillary glomerulonephritis, other conditions that were surprising. Comparing diabetes and chronic kidney disease participants to controls, we found a differential expression of 112 autophagy-related genes in the proximal tubule. And this is out of a set of about 600 autophagy-related genes from the literature. 47 of these genes were upregulated and 65 these genes were downregulated compared to controls without diabetes or kidney disease. And this is a heat map showing those findings. I then clustered individuals with diabetes and chronic kidney disease by proximal tubular autophagy gene expression, meaning I applied an algorithm to group people based on how similar they are in terms of autophagy gene expression. This grouping only used autophagy gene data and did not incorporate any clinical information. And again, this grouping was only applied to people with diabetes and CKD, not the controls. 3 groups became apparent. Group 1 had 17 people. Group 2, cluster 2, had 9 people. And group 3, cluster 3, had 6 people. Looking into the characteristics of the members of these clusters, what I'm showing you here in this bar graph is the distribution of biopsy diagnoses across the 3 clusters. And we found that cluster 3, interestingly, had no individuals with biopsy-proven diabetic nephropathy. So these are all people with diabetes and chronic kidney disease who did not have Kimmel-Still-Wilson nodules or the classical findings of diabetic nephropathy on biopsy. There was an even distribution in this group of people with diabetes and hypertensive nephrosclerosis. This is where our other diagnoses fell in, like the IgA nephropathy case, and a large proportion of people with those non-specific findings precluding a clear diagnosis. Meanwhile, cluster 2 seemed to have the highest proportion of people with diabetic nephropathy. That's the red coloring here. And cluster 1 had a distribution of all of our diagnoses. So I'm going to label these groups for ease. Cluster 2, the diabetic nephropathy group, because that's what we're mostly seeing here. Cluster 3 is the non-diabetic nephropathy group, because there is no diabetic nephropathy present. And cluster 1 as diabetic nephropathy light, because there is some present, but we're also seeing other diagnoses. So what we found is that despite those differences in pathology, the clusters didn't seem to differ too much in terms of our traditional clinical measures for assessing kidney function. GFRs are pretty similar across the 3 clusters. Shown here are p-values. And there is a range of albuminuria present in all clusters. Cluster 2, the group with the most diabetic nephropathy, did have significantly more albuminuria compared to at least this other cluster. But overall, you could see that there's a broad range throughout. We also found that there was a broad range of diabetes durations present in each cluster. You see the rainbow of years of diabetes present throughout. There isn't a clear pattern here. But interestingly, when looking at hemoglobin A1C, it appears as though cluster 2 members, the diabetic nephropathy group, have the highest A1Cs. The purple bar here represents A1Cs greater than 8.5%, whereas cluster 3 members, the group that did not have diabetic nephropathy, had the lowest A1Cs, below 7.5%. And again, in cluster 1, which I've been referring to as our DN light group, has a range of A1Cs. At the molecular level, we assessed the proportion of normal versus damaged proximal tubular cells present across the clusters. And these labels for whether the proximal tubular cells were normal or damaged, reflecting adaptive or maladaptive or repairing cell repair processes, is based on molecular expression data that's been annotated by the KPMP group previously. So what we found was that cluster 2 members, the diabetic nephropathy group with higher A1C, seemed to have less normal proximal tubular cells and more adaptive, maladaptive repairing cells than the other clusters. And so what this suggests is that there's more injury at the molecular level in this cluster compared to clusters 1 and 3 that have more of a range. I then created autophagy activity scores using various sets of autophagy genes. The idea here was to determine, because these groups were made using autophagy gene data, to determine if we could figure out if one group has more or less autophagy activity than the others. And so what you could see here is that cluster 2, consistently across different ways of assessing autophagy activity using transcription data, are demonstrating more autophagy activity than either clusters 1 or cluster 3. Cluster 1 is consistently showing a range of autophagy activity. And I want to point out that here, the TFEB score, TFEB is a master transcriptional regulator of autophagy. So it transcribes sets, or it triggers transcription of genes that activate autophagy. And here we see a really clear separation between cluster 2 and cluster 3, with cluster 2 having more expression of these genes that promote autophagy, and cluster 3 having far less expression of these genes, with cluster 1 having a range. To further try to understand what distinguishes these clusters at the molecular level, I identified differentially expressed genes between the clusters, and these are presented in the dot plot here. And as you could see, there are clear differences in autophagy gene expression between the 3 groups. Clusters 2 and clusters 1 and 2 were the groups that had people with diabetic nephropathy in them. And you could see that the coloring is pretty similar across these 2 clusters. But these two clusters are very different from cluster 3, which had people without diabetic nephropathy in them. I tried to link the genes that differed between these groups to specific steps in autophagy. And on a cursory look, it appears as the genes in clusters 2 and 3, or in clusters 2 and 3, there is greater expression of genes that are involved in autophagy initiation and lysosomal function, which is consistent with the autophagy scores that I've been sharing, showing more autophagy in this group. But compared to cluster 3, decreased expression of genes involved in the fusion of autophagosomes with lysosomes. So again, autophagy is a very complex process with multiple steps. And what we're seeing here is that there are differential expression of genes pertaining to these different steps across these groups. So summarizing findings from the cluster analysis, among people with diabetes and chronic kidney disease clustered using only autophagy gene expression data, I identified 3 clusters. Cluster 2 had predominant diabetic nephropathy. Cluster 3 had no diabetic nephropathy, and cluster 1 had some diabetic nephropathy. Cluster 2, again, had the most diabetic nephropathy, the highest A1C, more tubular injury on pathology, which is information I did not show here for time, less normal and more adaptive cells, and the most autophagy activity. In contrast, cluster 3 had no diabetic nephropathy, a lower range of A1C, less tubular injury, both normal and adaptive cells, and comparatively less autophagy activity. And cluster 1 seemed to sit someplace in the middle with a range of pathology on biopsy, diabetic nephropathy, hypertensive nephrosclerosis, etc., a range of hemoglobin A1C, some tubular injury, both normal and adaptive cells, and a range of autophagy activity. In terms of future directions, I'm hoping to validate this work in other cohorts with available single-cell RNA sequencing data. And I'm also interested in deciphering how the specific components of autophagy differ between these clusters. As I mentioned, there was a signal for more genes involved in autophagy initiation and less in fusion of the autophagosome with lysosome in cluster 2 compared to the other clusters. I'm also planning on correlating these genes with blood and urine biomarkers and determining associations of autophagy gene expression with long-term changes in kidney function. And as a much longer-term goal, I'm interested in bringing precision medicine to diabetic kidney disease in clinic. So understanding how the patient in front of you, how their disease course is different from other patients with the same condition, and what treatment strategies should be given to them specifically. So in conclusion, autophagy is the process by which cell products are degraded and is essential for cellular homeostasis. Changes in autophagy-related gene expression are apparent in diabetes and chronic kidney disease, and proximal tubular autophagy-related gene expression patterns may be able to distinguish between clinically relevant phenotypes of diabetes and chronic kidney disease that do not otherwise differ by traditional markers of kidney function, GFR, and albuminuria. And I want to thank all of my mentors here at the University of Washington, specifically Ian DeBoer, who's been my mentor since I started here in 2018. Thank you all.
Thanks so much, Dr. Limonte. We have some time now for some questions, so please continue to place those in the chat if you have any. I'm going to start with a question directed to Dr. Yogeswaran, which is, are you aware of any disparities in the management of atrial fibrillation, particularly around access to anticoagulation, such as DOACs, as well as other interventions inclusive of ablation?
Yeah, great question. So I think most of the literature to date has only been focused on non-Hispanic Black adults versus white adult populations, but I think based on a lot of Medicare claims data and like VA studies, non-Hispanic Black adults are less likely to be prescribed DOACs despite having higher stroke risk scores. I think some of it stems from people assuming that warfarin is better when patients have a risk of stroke and people not necessarily following guidelines. I think one of the other issues with a lot of things in cardiology and probably medicine is oftentimes racial and ethnic groups are underrepresented across these studies. But the things that we do know based on larger cohort data is people are non-white patients are less likely to be prescribed DOACs, less likely to be on anticoagulation despite having a high CHA2DS2 VAS score. They're also less likely to be offered an ablation. And for patients who are perceived to be high bleeding risk, I think we often see clinically that these patients are less likely to be referred for a left atrial appendage occlusion device as an alternative if they're still high risk for atrial fibrillation. But that is all I know for now.
Wonderful. Thank you. And a question for you, Dr. Limonte. Do you know if the use of metformin, which promotes autophagy, differs between the three clusters that you studied?
That's a great question and not something that I've looked into. We do have medication data on these individuals, and that's something that I will be mapping out. But to expand on your comment on how metformin promotes autophagy, that is something that's well known. So the nutrient sensors of autophagy are AMPK and SIRT1, and we know that AMPK is AMPK activation triggers autophagy, and we know that metformin triggers AMPK, which should theoretically trigger autophagy. So that is definitely something that I want to look into. And there's also, I want to add that there's also some growing evidence that SGLT2 inhibitors and GLP-1 receptor agonists stimulate these same pathways and can promote autophagy, which may be one of the mechanisms by which they have kidney protective effects.
And another question, should more patients with assumed diabetic nephropathy undergo biopsy given your cluster 3 findings?
Yeah, so I think, my bias from participating in the KPMP is that biopsy does tell you more than you think it's going to tell you. And a couple of papers have come out from the KPMP examining clinician and patient participant responses to the biopsy. And what participants reported was that even if the biopsy didn't change the diagnosis, it helped their understanding of kidney disease and helped them understand and help them talk with their doctor about prognosis more. So my bias from this is I am more inclined to biopsy my patients with diabetes and chronic kidney disease, not just because it can demonstrate, lead to a diagnosis that I wasn't expecting, like fibrillary GN, but also because it does seem like it would be useful for having conversations with patients. And we're also finding that the risks are really minimal. We're not having a lot of major complications from biopsy. It is safe and well tolerated.
To that end, I'm curious, so your cohort of patients, you saw only about a third of them had clear diabetic kidney disease on biopsy. Are similar rates of DKD seen in populations of patients who have comorbid diabetes and CKD? And then how do you kind of conceptualize now the histopathologic diagnosis of CKD etiology as compared to maybe some of these future bio and genetic markers?
Yeah, so these are awesome questions. There are a few, the only way to really assess the first question of in the general public of people with diabetes and chronic kidney disease, how many people have diabetic nephropathy, is with a study such as the KPMP that is, just biopsying people with those conditions. What happens there aren't too many research studies that have done that. Most of the studies that are published about biopsies in diabetes and chronic kidney disease are using clinically indicated biopsies. So like retrospective studies using clinical data from people who who had biopsies for a clinical indication. So that population is different. Those are people who are biopsied because they have hematuria, a faster decline in GFR than expected, or more albuminuria than their provider is expecting for diabetic nephropathy. They're the providers doing the biopsy because they're expecting something different. We do see there have been at least 1 or 2 studies comparing like stricter versus less strict protocols for biopsying people with diabetes and CKD. And yes, if you biopsy, if you have a less strict criteria, if you biopsy more people, you see more of that range where less people have diabetic nephropathy and more people have, hypertension or other conditions. So this is a question that we're hoping to answer within the KPMP. And then your second question.
How you conceptualize
Yeah.
the histopathologic diagnosis of the etiology of CKD versus biomarkers and other.
Yeah, so I think so right now a diabetic kidney disease is seen as a primarily glomerular process. The diagnosis for diabetic nephropathy, like on kidney biopsy, is meeting certain glomerular criteria. So the vasculature, the tubules are excluded. So what I'm thinking is we'll be seeing in the next several decades is as we start to incorporate molecular data about injury in the cells and changes in metabolism of the cells in response to glucose, long-term glucose exposure diabetes, that will be kind of the foundation for, molecular diabetic kidney disease. And then we will be mapping pathology to those like gold standard, truth molecular changes. So what I'm expecting in the future is that we will be thinking more about the tubulointerstitium and the vasculature in the diagnosis of diabetic nephropathy. But for right now, we're very glomerular focused.
Awesome. Thank you so much. One more question for Dr. Yogeswaran. Recognizing that you commented clearly more research is needed in this area of atrial cardiomyopathy, can you imagine a future where the identification of atrial cardiomyopathy or even these abnormal P-wave indices is potentially impacting both clinical screening and prevention strategies for atrial fibrillation? And how might that look to you?
I think it's something I've been thinking about a lot lately because I feel like I'm still trying to figure out how to combine my clinical work with what I'm studying. But I think in an ideal world, you'd have like a preventative cardiology clinic and every patient would have their ECG auto-analyzed for a bunch of risk factors. And it would tell you if somebody is like moderate, high risk for certain events. And I think it could I guess in the near term future, I think it could guide decisions like who would be likely to be on an aspirin or statin. I think because there's still a lot of hesitancy around being on statins. I think long term, it would be interesting if that could be applied to things like Apple Watches. And I think there's some work being done at the CHRU kind of automating ECGs. So that's part of where this comes from. But I feel like, yeah, a clear next step would be I think a lot of it's becoming increasingly hard to get a primary care physician. So if we had a way to automate this even before you were being seen, I think it would be informative.
Awesome. Thank you for that. And thank you to both presenters today. Really wonderful talks. Thanks for sharing your work with us. And we wish you obviously a lot of luck as you move forward and success in your careers as both researchers and clinicians.
Thank you. Happy to be here.
Thank you.